Welcome to this video on Ventilator Graphics, presented by Dr. Salem Keshba. We will explore waveforms, loops, pulmonary, mechanics, loops, how to identify desynchrony, and bedside troubleshooting techniques. This video covers 10 key topics, beginning with a historical timeline, moving through the role of waveforms, basic scalars, loops, and patient ventilator desynchrony, and concluding with management, troubleshooting, special situations, and a summary. Ventilator graphics have evolved from early concepts in the 1920s and the development of CPAP in 1971 to the modern real-time digital displays we use today. Understanding these waveforms is essential for identifying physiological processes, monitoring disease, and optimizing settings to minimize complications. Ventilator graphics fall into two categories: basic scalars, which plot a single variable against time, such as pressure, flow, or volume, and loops, which combine two scalars into a two-dimensional display, including pressure volume and flow volume loops. In pressure waveforms, we track peak, resistance, plateau, and peep. In flow waveforms, inspiratory flow appears as a positive wave, while expiratory flow is negative. The shape of the inspiratory flow wave helps differentiate between volume control and pressure control modes. Volume waveforms help assess tidal volume delivery and identify air leaks. While clinicians often monitor the numerical data, it is vital to inspect the flow waveforms directly during modes like SIMV to accurately interpret the delivery of both spontaneous and mechanical breaths. The pressure volume loop demonstrates hysteresis, where the inspiratory and expiratory limbs differ due to the resistive work of breathing. This loop provides a visual representation of how the lungs change shape during a breath. On a pressure volume loop, patient effort is visible in the lower left quadrant as a trigger. If the loop flattens away from the dynamic compliance line, it indicates increased airway or circuit resistance, which may point to issues like a kink tube or secretions. When interpreting PV loops, note that decreased compliance rotates the loop toward the x-axis, while increased compliance shifts it toward the y-axis. Beaking at the top of the loop signals overdistension, suggesting a need to wean pressure to avoid alveolar trauma. A PV loop that fails to return to zero volume confirms a circuit leak, while a figure of H shape indicates, quote, air hunger, where the patient is not receiving adequate flow, necessitating an adjustment to the flow or rise time settings. The flow volume loop maps volume on the x-axis and flow on the y-axis, with inspiration above the baseline and expiration below. The effort-independent portion of the expiratory curve is particularly useful for assessing airway resistance. Different obstruction patterns create distinct loop shapes. Extrathoracic obstruction flattens the inspiratory limb. Intrathoracic issues flatten the expiratory limb, while fixed obstructions affect both or scoop the expiratory limb. Turbulence will create a characteristic sawtooth pattern. Airway leaks in a flow volume loop appear when the expiratory limb doesn't return to the zero volume point. If the expiratory loop is missing entirely, it serves as a critical, high-confidence indicator of accidental extubation. Desynchrony occurs when ventilator settings don't meet patient demands, potentially increasing work of breathing and risk of morbidity. It is categorized by the respiratory phase, triggering, flow delivery, termination, or expiration. In trigger asynchrony, ineffective triggering happens when patient effort fails to initiate a breath. Auto-triggering occurs without patient effort, often due to leaks, while double triggering happens when the patient effort exceeds the set inspiratory time, creating a risk of breath stacking. This video covers flow and termination asynchrony. Flow asynchrony occurs when gas delivery is too fast or too slow for patient demand, causing a concave, scooped-out pressure tracing. Premature cycling happens when the ventilator ends the breath before the patient's effort is finished, while delayed cycling occurs if the patient initiates expiration during ongoing inspiratory flow. Expiratory asynchrony can lead to autopeep, where gas trapping occurs because the expiratory time constant is violated. This is seen as increased peak airway pressure. Managing this involves adjusting settings like flow or rate to allow for complete exhalation. Additionally, monitoring compliance and resistance by gestational age is crucial for appropriate ventilation. Bedside management involves optimizing key parameters like PIP, flow, and inspiratory time using visual feedback. For example, excessive circuit flow can lead to overdistension and unintended PEEP. Real-time displays allow the team to predict patient discomfort early and ensure that tidal volumes remain within the optimal range. Effective troubleshooting uses graphics to identify underlying issues. For instance, air trapping is identified by a scooped expiratory curve and delayed return to baseline. Decreased compliance results in a more horizontal PV loop, while increased resistance manifests as a fatter loop with bulges in either the inspiratory or expiratory limbs. Additional graphic patterns help identify other common issues. Overdistension is classic for a, quote, a bird beak at the top of the PV loop. Circuit leaks are detected when the expiratory limbs do not return to baseline. Partial obstructions cause jagged, fluctuating loops, while active exhalation is seen when the expiratory waveform crosses the zero point. Surfactant administration leads to rapid improvements in compliance, but it requires careful monitoring to prevent overdistension. Following surfactant use, clinicians must watch for alarms related to low tidal volume, as the lung mechanics shift rapidly. Changes in the flow volume loop help differentiate between normal and BPD-affected lungs. Special ventilator modes, such as HFOV, rely on unique waveforms depending on the specific oscillator used. For any mode, clinicians should remain alert for pneumothorax, which can manifest as sudden autocycling and a drop in tidal volume, indicating a potential leak somewhere within the system. Despite the value of ventilator graphics, they have limitations. Non-invasive ventilation often suffers from variable measurement accuracy due to interface leaks, and esophageal pressure loss during these procedures can further obscure the true data. Furthermore, reliance on numbers over waveforms can create a knowledge gap in clinical practice. For self-assessment, consider common board-style questions. A PV loop that fails to return to zero volume is a hallmark of a circuit leak. Similarly, when the expiratory portion of the loop is missing entirely, it is a critical sign of accidental extubation, providing an unambiguous warning to the clinician. In summary, mastering ventilator graphics is essential for neonatal care. By understanding the combination of scalars and loops, monitoring for dysynchrony, and recognizing the patterns associated with complications like leaks, obstruction, or pneumothorax, you can significantly improve your ability to manage and troubleshoot your patient's ventilation at the bedside.